Right on, thank you. Okay, awesome. Very cool to be here in the Twin Cities. My first time in a long time. I think I came to a wedding here back in about 30 years ago. So very excited to have this opportunity to talk to you guys today about something that I'm really passionate about. So we'll get started here. I updated my DoD disclaimer because now my only disclaimer is that I'm retired from the DoD and the Department of, I actually refuse to call it the Department of War still. So Department of Defense. I have no conflicts of interest, but I always like to point out that I do have an interest in conflicts. So a little bit about the Joint Trauma System. At the Joint Trauma System, we have a mission to improve trauma readiness and outcomes through evidence-driven performance improvement. So this is the part of the Department of Defense that really focuses on improving trauma care. And this triangle here represents how we see the world. So you start with care delivery. As you do liver care, you should be documenting, hopefully, that results in data that is abstracted into the trauma registry. This has been a very manual process over the years so far, really working on electronic documentation, automated transfer of data to the registry, hopefully going forward, analyze that data for the purpose of performance improvement, develop best practice guidelines, which should then contribute to improving the care that is delivered, and this results in a continuous cycle of improvement. So that was my job for 7 years, and I want to talk today about some of the more impactful research and analysis that we did. This study came out in 2012. It actually came out, it was published while I was literally deployed as the Joint Theater Trauma System Director, which is the job that Greg had before me. That was my job in 2012. And this was an analysis of all of the combat deaths from the first 10 years of the conflicts in Iraq and Afghanistan, 2001 to 2011. And this was just flabbergasting to me. 90% of the deaths occur before the patients even got to the hospital. I mean, I was working at the Roll 3. We were working day and night, working our tails off, doing brain surgery, limb salvage, massive resuscitation, all this stuff. And 90% of the patients didn't even make it to us. And like, as a trauma surgeon, I did not really realize that before. And the DoD took this very seriously. And it really said, where, if we were to try to save more lives, where would it be? And even more impressive, 90% of those deaths that were determined to be potentially survivable, 90% of them were due to hemorrhage. There's a few airway obstructions, a few tension pneumothoraxes, but that idea of better hemorrhage control pre-hospital, better blood product resuscitation pre-hospital completely changed the way that our trauma system worked. And it was really a matter of delivering those treatments earlier and closer to the point of injury that led to increased survivals. So this is an analysis looking at time, and this is looking at 5,269 trauma patients who were at least moderately injured. They had to have an AIS, injury severity, in one body region of 2 or greater. So the overall cumulative mortality was about 14% in this cohort of patients. What is truly remarkable about this mortality curve is the first day is literally vertical. So essentially, the vast majority of the deaths are occurring very quickly. In about half of the patients, or 2,362, we had times of injury, time of medevac arrival, time of hospital arrival, et cetera. And we were able to plot this 24-hour survival curve. And again, it's still incredibly front-loaded to the early hours. In fact, 68% of deaths in our trauma system occurred within 1 hour of injury, and 90% of deaths occurred within 4 hours. Put another way, the longer you survive, the more likely it is that you will continue to survive. So after you survive 4 hours, you now have a 90% chance of living, and only 10% of deaths occur after the first 4 hours. And so it just really gives you the sense that in the urgency that we need to deliver these treatments early after injury, which led us to state the obvious. Life-saving treatments delivered too late do not improve survival. Like, this cannot be more obvious, but as I go on through this talk, I'm going to show you how in our trauma literature, we completely fail to recognize this, sort of mantra of trauma care. We also set out to look at literally like when is too late for certain interventions. These are the key interventions that we really described. Things that need to happen sequentially after injury in order for you to survive for further care. So number one, within minutes of your injury, external bleeding control and clearing the airway are super important. This is things like placing a tourniquet, things that can happen really quickly. Airway clearance, sometimes that's just literally getting them out from a burning vehicle or extricating them from something that's crushing them and preventing them from breathing, getting blood out of their airway. This is not an advanced airway treatment, just very quick at the point of injury. Initial blood product transfusion, handoff to surgical care, the first emergency surgery for those that need that type of damage control surgery, and then for those with severe TBI, that need craniectomy, that needs to happen. So talking first about the blood transfusions. When I was deployed in 2012 as the Joint Trauma System Director, that was the same exact time that we started doing pre-hospital blood transfusions on our medevac helicopters. And this was quite the novel treatment at the time. This was the first time we actually had storage containers, which we kind of take for granted. They're just those little refrigerated boxes that you freeze and then you can put blood in them. That technology to keep those things frozen in the desert did not really exist before around this time. And so that kind of led us to have the capability to be able to carry blood on the medevacs. And we looked at our first experience for the first 3 years of that capability. So the study population was US military casualties in Afghanistan from 2012 to 2015. And retrospective comparing 500 patients who did not get transfused to 55 who did, 55 only, very small cohort. And one of the unique things about this cohort is that as we brought this capability to transfuse blood to our medevacs, we started with one site, trained them up, started delivering that capability, added another site. So sequentially, we had more and more sites that could deliver blood transfusion, but simultaneously in the same theater at the same exact time. So that was a concurrent cohort of patients who had the same indications to receive pre-hospital transfusion, but the medevac just did not have the capability at the time. And that was our basically control group. It was very busy, but there's a couple of things I want to focus on here. This was because I'm going to talk a lot about methodology in our trauma literature, and it's things that are very important in avoiding bias in our trauma literature. So this is a retrospective study design. They had to be alive at the time that medevac arrived. And had to have an indication according to our guidelines for pre-hospital transfusion. I mean, we compared patients who had an indication for transfusion to those who also had an indication and received transfusion. These are the covariates. Covariates are what you use to match your two groups. So we have a group of recipients, a group of non-recipients. What are the covariates that we're going to use to match those groups? Very important that the covariates, there's something called a collider bias, where you use an outcome to define your cohort, and that will actually could potentially completely reverse the results. So we try to use covariates that are visible to the medic at the time of injury. So the mechanism of injury, gunshot versus explosion, it's kind of specific to the military. but that was essentially all of our patients were injured by one of those two mechanisms in that cohort. Did they have an indicator for hemorrhagic shock? Yes or no, based on vital signs. How many amputations did they have, since we were seeing so many amps? And then we used AIS for the head and the torso hemorrhage. One thing very important to note is that if you're using these injury severity scores without autopsy results, that can actually reverse the results of your study. So when you see any study that's using an injury severity score or an AIS score to control for the severity of injury, my number one question is, did they have autopsies when they assigned those AIS scores? So for example, just to sort of make it more obvious, if you get shot in the heart and you don't have an autopsy, your injury severity score could be 1. You get scored for a skin laceration because you can't see that the injury to the heart until you've had an autopsy. So in this group, 45 patients that were non-recipients were able to be matched to the recipients. The ones that didn't match typically were too minorly injured to have an equivalent person in the recipient group. So what do we find? These are the survival curves over 24 hours. And you can see that this is a mortality curve. Very important not to confuse mortality and survival. Mortality curve, the lower the better. The lower mortality, the better. So you see in green there, the recipients of blood transfusion had a significantly better survival, and the hazard ratio is 0.2. So I'm not a statistician. I always get kind of confused with these things, but the closer to 0 the hazard ratio is, the better. So that is a very strong signal of a strong survival benefit with pre-hospital transfusion compared to in-hospital transfusion. Oh, sorry, I need to go back. 30-day mortality continued out, the survival benefit. So if you survive the first 24 hours, you are likely to survive the full 30 days. And this is what kind of really made us change our thinking. This is a plot in blue. The blue dots are people that got pre-hospital transfusion at a certain time. This is minutes from the time the medevac arrived to the time they got their first transfusion. And in red is the in-hospital transfusion. Some people actually got to the hospital and got a blood transfusion faster than some of these people here where the medevac was delayed. And so we thought about, what really does the patient physiologically care about? He doesn't care about if you're on a helicopter. He doesn't care about if you're on the ground. He doesn't care about if you're in the hospital. He literally just cares about how fast can I get this life-saving intervention. It doesn't matter where they are. And so when we looked at time to transfusion, and we started off looking at time from medevac to transfusion, but we knew the time of injury to transfusion was the most important. We were really only able to estimate that time from injury to medevac arrival. But we came up with an estimate of 36 minutes after injury was the cut point. And so this survival curve shows in blue those patients who received transfusion within 15 minutes of medevac arrival, approximately 36 minutes after injury, had a very, very significant improvement in survival. And here you can see hazard ratio 0.17. So very, very strong signal for those patients that were transfused within 15 minutes compared to any time after 15 minutes. But even more impressive, if you got transfused 5 minutes later, now there's no difference in survival. Like, this really made us think, like, holy cow, like every single minute here matters. And that really drove us to set up our trauma system, train our medics, deliver blood products to the field with a goal of transfusing within 30 minutes. Now, this study, it was published in 2017. I consider it more hypothesis driving than anything. A very small cohort of 55 blood product recipients. I would love to see a much larger study, a prospective study, but interestingly, all of the studies that have come out since then do not take into account time to transfusion, which is mind-boggling to me. The next thing we looked at was time to surgery. So similar type of analysis, but looking at time from injury to handoff to a surgical team. Not necessarily the time to the actual surgery, although we did include that in the analysis. So we'll see here, this is the cohort that we studied that had surgery or indications for surgery precluded by death. And I think that second part, indications for surgery precluded by death, is a very important part of our methods that help us avoid the survivor bias. So let's say you define your cohort by patients who actually had surgery. That means anybody that died before they got surgery is not accounted for in your analysis. So very important to consider. And about 1,500, like about 2/3 of them had enough times recorded in our registry that we're able to use them for analysis. We did compare the non-missing times to the patients who had missing times, and they were virtually identical in the variables that we measured. So this kind of helped us support the golden hour. Those patients who arrived at a surgical team within an hour had a remarkably different survival compared to those who arrived after 1 hour, the hazards ratio of 0.34. And similar to the blood transfusion, if they were handed off to a surgical team 30 minutes later, we really didn't see any significant difference in their survival. So between 60 to 90 minutes versus longer than 90 minutes, really didn't see a difference. And this was largely because, like we showed in the very beginning, the vast majority of deaths have already occurred by that time. And then we started looking at patients who had surgery. Those patients who arrived at a surgical team within 1 hour and then had surgery had a much better survival compared to those handed off later. That's a little bit obvious, but this is what is interesting, is once you were handed off to a surgical team, the actual time to surgery didn't really make a difference. And so those who waited less than 1.2 hours compared to those who waited longer than 1.2 hours, the reason those hours are like kind of 1.2 is kind of seems like a random time, but it was a quintile. 1/5 of the total patients had surgery within 1.2 hours. And we're scratching our heads at this, but our hypothesis is that once you are handed off to a surgical team, you now have a much higher capability to diagnose the patient and triage those patients who really need surgery super fast to get surgery quickly, and those patients who can wait can safely wait because they've been essentially cleared of massive hemorrhage. So that on average, that in-hospital wait time seems to not have an effect, but I think we all know that there are certain patients that really can't wait to get to the operating room, like that cardiac arrest patient you guys were describing. So timeline of life-saving interventions is kind of our graphic that we use to help explain this, but from the time of injury, within minutes, we don't really have good data, that granular of data to show, like, do you have 3 minutes or 4 minutes? I'm sure it's related to the individual. But within minutes, we need to control massive hemorrhage and clear the airway. Within about 30 minutes, transfuse blood. Within about an hour, get them to a surgical team capability. After 4 hours, that's really the time when you're likely to continue to survive, and we kind of transition to what we call prolonged care at that point. Okay, that was a little bit from the trauma system. What I want to transition to now is I want to try to talk somewhat about biases in our trauma literature. And if I start like losing my mind during this, you'll understand why, because it actually kind of makes me insane. So this is a little war story. This guy's name is Dr. Wald. He was a epidemiologist, statistician type, who was hired by the military to help us in World War II. figure out how to make our aircraft more survivable. You can see as a P-42 getting shot down, very super bad problem during World War II. What he did was take the aircraft that were returning to the airfield and mapped out where essentially all the bullet holes were in the aircraft from the ground fire or the air-to-air fire. And you can see in red all the places where the damage to the aircraft was done. So if you saw this, where would you up armor this aircraft? In the fuselage, the engines and the fuselage, right? Like, so here's your engines. You get shot in the engine, you're likely to explode and not come back to the airfield. Fuselage, same thing. Aircraft is likely to break apart and not make it back to the airfield. So essentially, this is pointing out that if you only look at the aircraft returning to the airfield, you're really missing the main point of the whole thing is how do we solve this problem of the aircraft that are not making it back to the airfield. So let's talk a little bit about survival bias. It's weird. It's different than the picture that's up there. Odd. They're stuck on the airplane. barely started within 1 hour. So essentially, what have we just proved here? Back to our very beginning slide, life-saving interventions delivered too late do not improve survival. We spent $4 million proving this. I'm already getting mad. All right. Why? Why do we do this? So, I mean, like if they had done the analysis differently, and I'd love to get my hands on this data, because if you did account for time to transfusion within their data set as you did the analysis, I think the outcome would have been different. And I think we could have come up with a timeline that could have helped us understand in the civilian trauma system where that cut point is. 36 minutes on the military side. I think it would be very interesting to see how that compared. PAMPER trial, this was a study that looked at pre-hospital plasma transfusion during medevac transports in several civilian trauma sites. Interestingly, their intervention was to give 2 units of plasma, but the control group, half of the control group had red blood cells, and half of the control group only had crystalloid. So it was basically plasma plus red cells or plasma plus crystalloid kind of all mixed in together, which was a little confusing in terms of the control group. And their main outcome was mortality at 30 days, which is a very long delay for mortality outcome in a hemorrhagic shock trial. Patients transported from scene and hypotensive. And they did find in this study that the mortality with the plasma recipients was actually better. They really didn't report the time from injury to transfusion. They only reported the length of the transport time itself. So that made me wonder, how fast this was actually getting delivered. A lot of our civilian trauma systems, the ground ambulance will respond first, and then they'll call the helicopter, and the helicopter isn't necessarily getting there all that fast. So I suspect that in this trauma system, there was a significant delay to transfusion. Interestingly, at the same exact time, or very close to the same time that this PAMPER study was published, there was another study called COMBAT, which is essentially looked at the same thing, pre-hospital plasma transfusion, and they showed no benefit. But again, they really didn't tell us what the time to transfusion actually was. This is their survival curve that they published, and plasma had a better survival than the standard of care. But one thing that makes me always confused, time zero. Always got to look at what is time zero. It is so rare to find a study that time zero is actually a time of injury, which physiologically, that is what the patient cares about. Their time zero is the time they were randomized for the study. That is a completely random time frame the patient doesn't care about. The patient may be bleeding a lot, they may be bleeding a little. What they really care about is not when you get to them and decide to randomize them. They care about time from injury. And just to kind of emphasize, one way, as you're doing your Cox survival curve that I showed in the last study, the way to avoid that type of survival bias, you can see the yellow bars there. Those are the ones, this is just an example, just to illustrate how to do this more eloquently. The yellow bars are the recipients. They're entered into the survival model at the time that they actually receive the transfusion or the intervention, whatever your treatment is. And so for patient number 10, for example, they were a recipient, but they had 47 minutes before they actually received the intervention. And then once they receive the intervention, now they're counted as a recipient. So this is all a time-dependent survival curve that is actually a lot more work for the statistician, because I got to go one by one through each patient and enter them into the model. But is really the way to incorporate a time as a covariate, a time-dependent covariate into your analysis. Another simpler way to do this is just the quintile method that we used in a couple of our studies, where you take the quickest time, this is looking at craniectomies, time to craniectomy, quickest time was 30 minutes. Longer time was 33,888 minutes. You divide that into quintiles, so there's about an equal number of patients in each of the 5 groups. And then you essentially just compare group 1 to group 2 through 5. Group 2 through the later times. And you can see here, the fastest time does have the highest mortality rate, and then it goes lower, and then it kind of jumps up again between 4 and 5. And that was right at about 5.3 hours. So just an illustration of where we selected a cut point to target our trauma system development. Like, we want to have that neurosurgeon in a location where they can get to the patient within at least 5 hours. Faster is always better, certainly. And this was looking at the mortality outcome, which is not the best outcome for brain injured patients, as you know, but it did help us set up a timeline for planning purposes. So then I start going through the civilian literature, and I find this study that I'm excited about. It says, timing to first whole blood transfusion and survival following severe hemorrhage in trauma patients. I'm like, yay, they've finally done it. They've developed a time to transfusion study in civilian trauma patients. But you kind of look closer at their methods and you're like, oh my gosh, they exclude deaths within 1 hour of ED arrival. And I'm just like who are we trying to save here? Those are the people. So why have we excluded the first 1 hour of trauma deaths? I think a lot of times, a lot of studies do this because they think that the faster you die, the more likely it is that you have some type of unsurvivable injury that won't respond to treatment. And so somehow it's going to make our study more accurate if we eliminate all those early deaths. And nevertheless, in spite of that, they did show a benefit to those who received whole blood quicker compared to those who received it later. This is like survival within 24 hours and survival within 30 days. So the 24-hour and 30-day survival. And then they still showed a benefit. And then I'm only going to go over 2 more studies before I lose my mind. But this is time. This actually paper, I think, is starting to get a little closer to what we need to know. And it combines data from 2 other trials. PAMPER was the pre-hospital plasma trial, and STAMP was a pre-hospital TXA trial. And they had similar inclusion criteria. And so they essentially combined data from those 2 studies, and they showed that really looking at time to these life-saving interventions. And let me just show you on the next slide. The 3 interventions that they looked at was red cells, plasma, and TXA delivery. And this is the odds ratio of death for every single minute. So every single minute delay into one of these life-saving interventions increase the mortality, odds of mortality by like 1.015% for red cells, 1.021 for plasma, 1.042 for TXA. So very interesting. This doesn't give us, I do feel like, okay, we see that every minute delay is increasing your mortality, so we know that minutes matter. It doesn't give us that sort of really strong planning timeline that we can train to and develop our trauma system around. Like, when is it that we really need to try to get that care to the patient? Okay, so this one I included because it literally was published this month in the Journal of Trauma. And increase pre-hospital to total blood product administration associated with improved outcomes. And they basically hypothesized that the ratio of pre-hospital transfusion to in-hospital transfusion would impact mortality, suggesting that if you get more blood pre-hospital or sooner, then you'll have a better survival. They combined data from 6 other trials. So it's kind of a crazy mishmash of trials, but there was a reanalysis. And this was their inclusion criteria. Subjects were eligible for inclusion if they received 1 unit of red cells or whole blood pre-hospital. So they got at least 1 unit of pre-hospital transfusion. Already I'm thinking, oh my God, your outcome has defined your cohort. You're only looking at recipients of blood transfusion. And it's also a type of survival bias in that the patients need to survive long enough to receive the treatment. So how do we get around this? The only way to really get around this is to actually include all patients who were eligible or met the criteria for treatment. So let's say whatever your pre-hospital indications are, it's usually based on vital signs and maybe injury energy, something like that. And so those criteria should be used to include the non-recipients. Exclusion criteria. So important to look at the inclusion and exclusion criteria when you read the literature. Subjects who died within 4 hours of arrival were excluded to minimize survival bias. Like, wait a minute, you just like created a massive survival bias by excluding the first 4 hours of people who arrived at the hospital, and you think you're minimizing survival bias? Like, how is this possible? They need to survive 4 hours to be included in the study. So obviously the solution is to include those early deaths, and essential to account for time to treatment in the analysis. In all fairness, the data that they had, looking at those other 6 trials that they combined, did not actually report those times. And so like they just didn't have the times available, but they found, surprisingly, no significant association between 24-hour mortality and the pre-hospital, in-hospital transfusion ratio. They did do a sensitivity analysis, including those 4 deaths, which didn't change their outcome. But really, sort of my big question in all of this is, you know, life-saving treatments delivered too late do not improve survival. So if you really don't account for time to transfusion, you really can't say that your results are valid. This is a very, very small analysis that we did at the Joint Trauma System. We didn't publish it, so I wouldn't take this too seriously, but we were trying to just look at injury severity score and time to death because of this idea that people exclude those early deaths. And between those patients that had an autopsy that were designated potentially survivable based on the autopsy findings compared to those that were determined to be non-survivable on the autopsy, and comparing survivable to non-survivable, there was really no difference in the time to death. And so using time as a surrogate to sort of eliminate non-survivable injuries is, I think, not valid thinking. And finally, autopsy findings really strongly affect your injury severity score. If you assign an injury severity score to a fatality or a decedent without an autopsy, it significantly underestimates the internal injuries. It will probably overestimate the external injuries. And the time to death, so it dramatically underestimates in a time-sensitive manner. So the faster you die, like my shot in the heart example, you die immediately. You're not going to have probably any diagnostic interventions whatsoever, and that injury severity score will dramatically underestimate your true injuries. Whereas the longer you survive, you're probably going to get a CAT scan, maybe surgery, bunch of other diagnostic things that if you live long enough to have those other diagnostic interventions, then your injury severity score, even without autopsy, will be more accurate. So as you look at the injury severity scores reported in those studies, really just kind of think about, did they have an autopsy? On my final slide, these are the lessons from the Joint Trauma System. How to reduce preventable death. Initiate blood product transfusion within about 30 minutes after injury. evacuate high-risk casualties to arrive at a surgical capability within about 1 hour, and initiate decompressive craniectomy within about 5 hours after injury. If the study doesn't meet this timeline, you have to strongly, strongly question. And I would say these are approximate timelines. Love to have more data put behind this, especially on the civilian side. But if your study doesn't meet these timelines or doesn't even mention the time at all, you just have to like get back to the original question of, what matters here? Timeline of life-saving interventions. My email is up there if anybody has any questions later on. Happy to answer questions now. And if anybody has any offline questions that they don't want to ask in front of the entire group, I'll be around for a little while after.
Dr. Shackelford, these not work?
No, they don't.
Stand up and speak up.
Good morning, ma'am. I'm Ted Hagman, fourth-year surgery resident, prior HF2 and clinic Canadian.
Nice.
My question is, how do we, all of your data is from medevac timeline. How do we get medics informant for documenting our data? I was there, and telling the medevac team what time it happened was the most documentation.
Yeah, like as soon as you figure that out for me, let me know. The time of injury is the most common missing data field on the DoD side. It's also the most common missing data field on the civilian side. And so I would say even an estimate of time of injury would help us out dramatically. We did have in our data for the US MIL, we were able to use the time of 9-line call, which on the civilian side is about the same as the time of 911 call as a surrogate for time of injury. And so that we know doesn't occur exactly at the time of injury. It occurs a little bit later typically. But we are certainly looking at ways to electronically capture data on the battlefield, which so far is not really being too successful. So I think it's going to take like a real technology revolution because we're just relying on people to write this stuff down is not working. It has never worked. It's probably never going to work. And I think, honestly, it's going to take a technology revolution to be able to do that. I don't know. The Israelis have done a ton of stuff more where they're actually like collecting data from like your types of electronic wearable devices and electronically having the medics place a vital sign recording device. So they're collecting those devices. And I think it's really comes down to how can we capture this electronically in the future. But we have not yet figured out how to do that. And especially there's also the issue of electronic signature and being detectable from the enemy's, detection systems. And so it is a very tricky problem. Okay.
What are the biggest barriers to pushing blood products further forward, and how do we realistically overcome them?
Well, I say did everybody hear that? Given that we have shown that pre-hospital transfusion improves survival, what are the barriers to pushing that farther forward? So I would say probably the number one first biggest barrier is we keep publishing literature that shows that pre-hospital transfusion does not improve survival, which is true. Like if you just compare all pre-hospital transfusion to all in-hospital transfusion without accounting for time, now we know it doesn't help. And so those multiple publications, there's multiple medical directors out there that read the refill study and said, I am not going to provide this capability because clearly it doesn't help. And so that is number one. But there are quite a lot of EMS agencies who have sort of drank the Kool-Aid. They have chosen to either ignore the studies or understand why the studies are faulty and are really trying to push to get pre-hospital transfusion out there in spite of the literature that's been published. And in that regard, the biggest barriers come down to really funding. And so, you got to buy the storage containers, you got to buy the refrigerators, and then you have to figure out how to get a blood supplier to give you blood, which is a pretty huge barrier with our blood banks in the US between the two major suppliers, Red Cross and Vitalant, really are quite reluctant to provide whole blood and also just have a limited supply to deliver to the pre-hospital agencies. Waste can be a perceived barrier in terms of like you put this out to the EMS agencies and they don't use it that often. And so that could be handled by rotating those products back to the hospital. So it does end up kind of setting up a pretty complex system. In Colorado, we're actually looking at starting our own blood bank for the pre-hospital providers, recruiting our own donors within the small communities and sort of cultivating a population of people that want to support their local EMS agencies and having like a mobile blood bank van that drives around to small towns and gets blood from the locals. So it comes down to data, money, planning, and it can be overcome, but it is a lot of challenges for sure.
One more question is, climate bias, I think maybe it's political, but I think reader interpretation bias when some studies show less work, no work, or doing less of nothing compared to those studies they remember where you work really hard, you might get a good outcome.
Right, because time to treatment really doesn't matter. Well, you may as well just let the residents sleep all night. Her question is related to how much does AIS under or overestimate mortality? So those, I'm not sure I can answer your question with a great deal of knowledge on that topic. But the injury severity scores and AIS scores, for people that aren't familiar with it's abbreviated injury scale, which combined together with each body is assigned per body region, and then combining those together comes up with the injury severity score. They have been used extensively. They are well validated. However, there's a lot of bias in that entire body of literature based on lack of complete autopsy data. And so I think it just gets back to the question of did they have an autopsy or not. I think internally within a single trauma registry, a single trauma system, as long as you're assigning those scores consistently between different patients, it is a good way to compare one patient to another. There are some modifications of the injury severity score, which, for example, the AIS score will max out if you have one amputation on extremity injuries. But what if you have two amputations? That's definitely worse. What if you have to have a thigh amputation versus a below knee amputation? And so there are some modifications. The new injury severity score will actually account for that. Same thing like if you had an injury to the liver, the spleen, and the kidney. That's three different injuries that is not necessarily accounted for. So there is a lot of room for improvement on our injury scoring systems for sure.
I have another
Question from the chat.
blood inventory that is maintained at field hospital level, whole blood, platelets, etc.
So typical blood product inventory at the field hospitals has changed a lot over time. And we waste a massive amount of blood in our military hospitals. And so there has been some thinking that we should put less blood at the field hospital so we waste less. But in general, we try to keep at least what we would consider like the massive transfusion threshold of 10 units of whole blood. Ideally, sometimes we don't have enough whole blood, so we would try to put that much in component therapy at the field hospitals. The platelets are pretty hard to deliver. We are using cold stored platelets now up to 14 days. So that has made it a little easier to deliver platelets to the forward locations. And then we also train very, very vigorously on walking blood bank to be able to supplement whatever blood we have stored at those locations with fresh whole blood. So I think that, so like the bottom line answer to that question is we try to keep about 10 units of whole blood or whole blood equivalent and the capability for walking blood bank. It did take us a long time to convince our Armed Services Blood Program to actually supply whole blood, and which is surprising on the military side, since that's where most of the whole blood data kind of came from. And then, you know, on the civilian side, it's even worse because I think there's a financial incentive to break it up into components, probably. And so it is pretty hard to get those blood bankers on board. And there's not a ton of data to really support it, which so you kind of can't blame them and say, you know.
Time for one more question. Thanks, great talk. The data in the Western majority trauma system obviously revolutionized military trauma care, but also civilian care as well. And I look at your slide up here, and time and early intervention are obviously important. But we can handle that in the sort of urban civilian trauma setting. We haven't figured this out at all in the rural space. How do we take some of these lessons, research that are needed, and be able to deploy this in sort of rural civilian settings where it's a less common event, but still a highly lethal event?
Yeah. It is like in the timeline of EMS arriving at, so Colorado, for example, has the largest number of frontier counties, which is like more rural than rural, you know, and they do have this problem where just delivering care quick enough to these locations. What we don't really have good data on is for those really delayed sort of rescue responses, you know, there probably are still some patients that benefit from blood transfusion at that point, but we really don't have good data for those really delayed care situations. So I think number one, on the civilian side, we need better data, and we need to use time as a covariate when we do our analyses so that we understand the effective time on care delivery. So that would be number one. But number two, at least in Colorado, Texas, some of the places that are really pushing hard for whole blood, or well, whole blood usually, but or at least blood products, getting those out to the EMS agencies, like the really small little agencies, or coming up with a plan for some type of intercept to where they can intercept with the EMS as they're on their way to a trauma center that could be farther away. So just trying to look at all the ways that you can deliver blood, and it pretty much amounts to getting blood out to these little small agencies. Like, can we do drone delivery? You know, we have an app in Colorado where you can track the location of all of the blood products in the county or in the state at any given time, so that you know who can help you if you need blood, someone to bring blood. So I think getting better situational awareness, getting blood out farther into those communities. And then the other thing we're trying is this idea of civilian walking blood bank. And we haven't cracked this yet. There's really no, I don't think any states have approved this yet. I know John Holcomb down in Alabama has been like trying to drive that. The FDA has said it's outside of their sort of approval. So it's always going to be non-FDA approved drug. It's considered practice of medicine, not an FDA approved blood product. And then sort of organizing that whole process of pre-screening the donors, having the donors knowing where the donors are, probably using the EMS responders as potential whole blood donors. All of this is being talked about. So I think really just looking at novel ways to get blood supply to more remote locations is really the only way to do it.
Dr. Shackelford, thank you for an inspiring, outstanding talk, and for the residents, remember the lessons about statistics. That's critically important as you're doing your study. For the residents, you remain here, correct?
I think I'll
So back up to the 11th floor.
Leave.
For those here at the Austere Medicine Conference, it's across the hall, Lisa, right? Okay. And then, and anybody that's interested in the conference that didn't register, you're also welcome across the hall for the rest of the Austere Medicine Conference. Thank you very much.